So good afternoon. My name is Sharon Kaczkowski, as you've heard, and I am a medical legal occupational therapist. And for those listening and not familiar with medical legal OTs, we are typically retained by plaintiff and defense counsel to determine the disability of a plaintiff as a result of the subject injury sustained. And as Sarah mentioned, we provide expert reports and testimony regarding loss of work capacity, loss of physical and cognitive ability, loss of homemaking capacity, and provide opinions and evidence on future costs of care. So you can imagine all of those different areas that we provide opinions and assessment on. We need to access the client in their home. We see them in the clinic and at the workplace. So here we go. So as you all know, in March, the end of March, the Premier and the Chief Medical Officer recommended stoppage of the of any non-essential health services provided by health professionals. And non-essential health services were deemed to be those that are done generally to protect, promote, or maintain the health of an individual. And if they were interrupted, they wouldn't endanger their life, their health, or the safety. And non-essential health services could go ahead, but they had to be deemed by the health professional that it was urgent or that it was critical to preserving their life, health, public safety, and their basic societal functioning. Medical legal occupational therapy services were deemed to be non-essential, hence we did not see people in person. How have OTs been treating and assessing clients virtually? Well, for those clients who were previously known by the occupational therapist, continuing treatment and consulting virtually was an easy transition and effective in many cases. However, for the most part, OTs doing this kind of treatment is a new process, and we, like many of you, were learning on the go. Like you are doing now, we attended webinars held by our Canadian and provincial occupational therapy associations and colleges to get up to speed and to find out how others were dealing with providing their OT services to clients when they couldn't see them in person. From all that learning and trial and error, the following is what many of us are currently doing. As Dr. Ali pointed out, there's a bunch of procedures that things that you have to take into consideration. For us, we typically call a client first, and we need to determine their willingness to participate and to ensure that they have the computer device capability and to set a time for the video conference call. It must be determined whether the client requires in-person assistance with signing onto the computer and if assistance is available, such as Dr. Ali mentioned about the client with aphasic stroke or aphasia and stroke. Also, the number of the occupational therapists is provided in the event of difficulty signing into the scheduled video conference call. And some of my colleagues have mentioned that sometimes the video or the audio part of the assessment hasn't worked, and so they use it visually, the computer, and then they use the phone in order to speak with them and have the audio portion. As well, we give explanation regarding the privacy and the encryption of the video platform. We're utilizing the positives and the negatives. We also send a consent form to the client by email, and we ask them to sign it in advance, scan it, and return it back to us if possible. During the virtual interview, the consent form is discussed once again, giving us consent to conduct this virtual kind of assessment or interview. And if the client has not signed and returned the consent form to the OT, it can be witnessed virtually, so we can see the client signing it virtually, and also verbal consent is acceptable. Should they not have email access, we can go through the whole consent verbally, and they can give us verbal consent. That's acceptable by our college. The identity of the individual may be required and confirmed by showing a picture ID, such as a driver's license, to the screen. And a plan is made if the interview is interrupted, for instance, if the bandwidth has let go or whatever, that you've decided whether or not you're calling them back or if you're going to sign on to the video conference or a phone call is going to be completed. And we all agree that the interview will not be recorded. For the expert OT, the upside of virtual assessments are the assessment process can be started by completing at least the interview portion, and there's no health risk, and it is appropriate for all immunosuppressed individuals. It familiarizes the OT with the client and the client with the OT, and the in-person assessment can be better customized at such times we bring them into the clinic, and that also reduces the in-person time. In the past, functional capacity evaluations could take 2 days, 4 hours each day, or 8 hours in one day, and then followed by an in-person assessment at an individual's home, which could take anywhere from 3 to 5 hours, depending on the areas of assessment being required. So a lot of the time that we see when we do see the person in person, that time is reduced. And we found it also to be allow the occupational therapist to identify areas of the claim or injury which may require further clarification and investigation by the lawyer, so that the process can be expedited somewhat. The downside of the virtual assessments, as identified again by Dr. Ali, is that the client has to have and be capable of utilizing the technology. And the virtual assessments are very challenging for individuals with brain injuries, so that's a downside for sure. Also, a comprehensive evaluation examination of the individual may be difficult, and it is more challenging for the therapist to verify measures and draw functional conclusions about their abilities and limitations. We typically see people in their home functioning, and it is very difficult to conduct these kinds of assessments virtually, although not impossible. Standardized testing that is utilized during functional capacity evaluations and cognitive evaluations, as spoken to by Dr. Atkinson, they're done by standardized ways, and there's specific wording and specific observations that are required, and these may not be valid if administered virtually. And further, it's not known yet how virtually collected information will be interpreted and accepted by the courts. Then came April 30th, and the Premier and the CMOH decided that non-urgent and non-essential services could go ahead, beginning as of May 4th. So those occupational therapists who were anticipating this to happen and were collecting all our equipment, the personal protective equipment, the PPE, and getting all our ducks in a row, getting ready to be able to see patients, were able to resume very quickly after the May 4th deadline or restriction was removed. But the CMOH had said that each professional college had to set out their guidelines. So those were specifically set out by our occupational college, the Alberta College of Occupational Therapists. And our college has said that they assume that each self-employed OT is best suited to determine how to apply and implement the guidelines to their own unique practice. So the onus is on the occupational therapist. It is recommended that OTs continue to provide virtual services wherever possible. And if a virtual service delivery is not an option, the use of clinical judgment to determine whether the in-person service can be delayed or postponed without risk to the client, and to defer and postpone any in-person delivery of service if the client does not pass the pre-screening eval so that they have risk factors or signs or symptoms of COVID-19, then the evaluation or examination in person should not go ahead. But when we do see the person in person and provide our service, we have to ensure that the appropriate workplace controls are in place to mitigate the risk of COVID-19 transmission. The controls implemented will vary upon what type of service or the practice setting, so if the client is seen in the clinic or in their home. It'll depend on the client population, so if they're vulnerable, or fragile medically, or not able to perform personal hygiene. And also the type of service and how close you have to come in contact with the client, and can they remain masked, or can you keep 6 feet away from the individual, and are there other people in place? If the service is to be completed in person, all applicable engineering and administrative controls are in place. So I'll talk about those in a moment. Also, the supplies of the required PPE are available for the OT and the clients. And OTs and staff are adequately trained in the determination of the PPE as required, and they have to know how to put on, take off, and dispose of the PPE. Health Canada has developed risk-informed decision-making guidelines that itemize the variables, and 3 of these hazard controls are the engineering, which are things like keeping 2-meter distance, also having rigid barriers to protect you and the client from the client from you. Administrative, and that's his types of things that people change the way they work. So there's staff screening, training on enhanced cleaning for home visits to limit the virus transfer, and PPE. So Alberta Health Services has guidance on point of care risks, risk assessments, and continuing masking, and what type of PPE is required, and how to don, doff, and dispose of these, and the training that's required. So what are OTs doing to comply with these guidelines? Well, the college leaves the process, again, like I said before, is up to the individual OT to interpret from the Alberta Healthcare Services guidelines. Therefore, each clinic and each OT may operate somewhat differently. I have canvassed our private practice OT Medicolegal group, and a compilation of what is being done is we'll go through to ensure the safety of the clients and the OT. I believe it is reasonable for lawyers to ask what measures are being undertaken to ensure the safety of their clients before agreeing to or allowing their clients to undergo a personal assessment. So OTs are completing assessments and treating and consulting clients by phone or video conferencing whenever possible. Immune suppressed or medically fragile people are not being seen. When in-person assessments are necessary for med-legal work, much of the assessment interview is completed by phone video conferencing in advance, and this then reduces the in-person assessment time. The day before and the day of the in-person clinic or home assessment, the client and the OT complete a COVID-19 assessment questionnaire, which goes through all the different symptoms and to ensure that both are well. At the assessment, the OT and the client sanitize their hands. Temperature is taken with touchless thermometer. Masks are worn, and when desired, appropriate gloves and eye protection are worn. And the client is aware that 2-meter distancing will occur throughout the day. So other measures which are taken where possible, only one client is in the clinic at a time. In the clinic, the client only touches the equipment, devices, and the material. For instance, the client places on their blood pressure cuff or their heart rate monitor, which is used during a functional capacity evaluation, and only they touch the tools and are demonstrated with another set of tools by the OT. The number of people at a home assessment is asked to be limited, so it's just the individual who you're assessing is home. There's frequent hand sanitization throughout the assessment at the home and the clinic. Eye protection, gloves, masks are utilized according to the risk assessment. And the risk assessment has to do with how close you are to the individual, as also whether any bodily fluids may be passed between the client and the OT, or the OT and the client. Speaking moistly. At a minimum, sanitize all services, equipment, and the tools during and after the assessment. Other measures also include sanitizing the clinic daily and or between the appropriate cleaning solution as per the Alberta Health Services guidelines, Some clinics have plastic shield barriers between the client and the OT, so that 2 meters, in the event that 2 meters distance cannot be maintained, or the use of face shields are used. Demonstration of appropriate disposal of the PPE. No food or drink are going to be provided or allowed in the clinic. And in many cases, the OT will contact the client 10 to 14 days following the assessment to ask if the client has developed any COVID-19 symptoms, and to report to the OT, or report to the client, sorry, that the OT hasn't developed any symptoms. So much of our testing in the clinic is done using standardized methodology, and it requires 4 to 8 hours of time seeing the client. So by doing a lot of the interviewing portion in advance, that reduces the amount of the time we have to see the client in the clinic. And going forward, even without the COVID, I believe a lot of our assessments are going to change so that this reduces the in-clinic time, and by doing the work in advance, the interviewing portion that we can do by video conferencing. At home assessments, it's very difficult to do a virtual assessment. Because a lot of our opinions, or most of our opinions, are based on functional abilities and how an individual is able to function within their environment at home or in the community and at work. So I don't know that that's going to be possible to do in a virtual setting, and also to have us rely on what we're seeing as good enough for core purposes. This is a list of the occupational therapists from whom I received information on their COVID-19 practices. And I thank you very much.